Since it's after the lunch break, I'd like to start off with a few questions to get everybody roused again a little bit and activated. So I'd like to ask how many of you have visited more than one healthcare provider, doctor or hospital in the past year? Just raise your hand. So quite a few. And how many of you do you have a personal health or fitness device like a Fitbit or an Apple Watch? Yeah, it's maybe even more. And how many of you have used a clinical decision support system in the past year? It's quite a few people. And who has accessed their own personal health record, the electronic health record, in the past year? Well, that's quite a lot of people, and I wouldn't really have expected that, looking at the German situation. Okay, but still I think that what I acquired here is representative of what I'm going to talk about in the next minutes, and I'd like to thank Professor Roca and also Mrs. Gopal for setting the scene, and I'm going to revisit some of the aspects that have been talked about. What we're seeing, as demonstrated by the first question, is an increasing portion of shared care where people visit multiple providers. Patients visit their GP. Whenever it is necessary, the GP may refer them to different kinds of specialists which they visit over time. Patients may need to visit the hospital for an inpatient stay. And increasingly, patients also document their own healthcare data through mobile applications, mobile devices, which we also discussed on the first slide. And of course, this will lead to, and is already leading to, increasingly fragmented lab data as well. So some of the lab tests are being acquired at the GP, maybe just a few of them over time at long intervals. The specialist may again capture some of these lab tests as well, but has some additional lab tests that he will measure at certain intervals. And then usually at the hospital, we have a much higher density of lab tests, higher frequency, and also a higher broadness of these lab tests being carried out. And then, of course, if the patient has devices where she measures her own activity or she measures her own physiological parameters or even lab tests, then again we have a very high frequency of data that also comes into the play. But unfortunately, each of these data elements are stored in different systems which are not interconnected usually. And so paradoxically, we have a situation where we have more data but less overall access to that data. And this is the point where digital networks come in and can try to connect these disparate providers, bring them together, and try to achieve an overall view of these different pieces of the puzzle. And in the first part of my talk, I'd like to talk about different potentials that these combined data elements may pose, but then again also address in the next part the challenges that we have to address in order to achieve these goals, and then look at specific initiatives which are already underway in order to reach these goals and potentials that can be reached using the digital networks. So let's first start with a smaller potential, which is just a longitudinal view of a patient's lab data. So if we bring these individual pieces of laboratory data from the different providers and also from the patient together, then at least we have reached a long-time longitudinal view of all of the data elements captured throughout the lab history of a patient. And this can help us fill in the gaps to include data from other departments in the hospital or even from other facilities the patient has visited or even the patient themselves, which allows us to more closely follow disease progression and to avoid unnecessary repeat testing. But it becomes, of course, much more interesting once we include the additional data elements from the electronic health record by, for instance, including diagnoses throughout the, including diagnosis data from the different times the patient visits the different providers, including prescriptions, maybe surgeries, or even radio chemotherapy or chemotherapy. And this helps us to put lab data into context, to identify relevant conditions, events, or treatments that have a meaning for the lab values, that influence how they change over time, and it helps us also to identify possible confounders for these lab results. And this, of course, can provide the basis, the foundation for decision support for lab orders or treatment orders, also for clinical trial recruitment, where we can use the totality of data available either in the past or at the current moment in the electronic health record to determine whether a patient may be recruitable for a certain study and then put him on a screening list. And then, of course, it becomes even more interesting if we analyze large patient cohorts, bring data not just from one patient through various providers, but of large groups of patients together. And one possible use for that is case-based reasoning, in the sense that we have a single patient here who has a certain situation concerning their lab values, their diagnoses, their prescriptions, and prior treatments. And we can then identify similar cohorts of patients from the past, and then compare them regarding the treatment alternatives and the outcomes in order to support the decision process for that specific individual patient we've seen in the first place. And looking at it the other way around, we can, of course, again use larger cohorts of patients, take all of the data together that we have from them, and in order to derive a machine learning model, a disease model from them. And then again apply the disease model to individual patients in order to identify subgroups or endotypes, as was just mentioned for asthma, COPD, to derive prognostic indicators or even for therapeutic decision support. Now, having visited the different potentials, I'd like now to take a look at the different challenges that we are facing. And first and foremost, we have to fulfill legal requirements. Just like it was mentioned already, data protection is an important legal obligation that we have to address, not just since the GDPR became active a few days or weeks ago, but even in the time before that. And of course, patient participation was already mentioned in the previous talks in order to get the patient to actively participate and provide information and also make personal use of that information. And one important prerequisite to achieve that is, of course, informed consent of the patients in order to inform them, to actively involve them in the treatment. And in some cases, if it's outside of clinical care for research, there may be some research exemptions where we can also use data in an anonymized, aggregated fashion, even if informed consent is not present. But in any case, ethics approval is required for these kinds of studies, and we have to take technical and organizational measures in order to protect the patient identities and prevent them from being re-identified through analysis of their data. Okay, and looking at the doctors, other legal questions and governance questions come into play, like for instance data ownership. When different practices, hospital organizations collaborate, they will need contracts for shared care unless these constructs are being mandated by the healthcare framework in that country. And if people collaborate for scientific use, we also need frameworks that define the use and access policies in order to gain that access to that information, in order to make sure that when that information is published and put into scientific results, that there's equal participation of the people who provided the data, took part in the analysis, etc. And so certain governance structures like use and access committees will need to be evaluated and established. And then also an important, increasingly important legal requirement is the medical device regulation, which is also tightening down in the European Union, which means that software which is being used for diagnostic or therapeutic decisions also needs to be validated. And we need to take care that these big data implementations, as was already mentioned, which in some cases can be quite hard to validate, need to be put through adequate studies, be they prospective or retrospective, in order to make sure that they actually fulfill their stated requirements. And then maybe the largest challenge of all from a medical informatics perspective is the semantic integration of these various disparate data sources. Starting, of course, with the question of using the right terminologies and data structures in order to harmonize data from the different sources. And one standard which is quite established worldwide for coding of lab values is, of course, the LOINC standard, which unfortunately in Germany is still very much at the beginning of being used for coding lab data, and we are trying to further that in an ongoing project, which I'm going to talk about a little bit later. And then HL7 file resources were mentioned also by previous speakers, which will help us define data structures which are compatible between the various players and systems in the field. And finally, combining these terminologies and data structures, we can then achieve common data models, which will allow us to actually combine the structure and the semantic meaning of these data models to allow overarching analyses and also overarching treatment structures across these different providers and databases. And within the care process, but also for extracting data for scientific use, of course, interfaces need to be established between the various systems and players. And for that, fortunately, standards have already been established, which are also being actively developed and furthered, like HL7 interfaces, but also IHE integration profiles, which can help putting different standards and data structures, terminologies together into consolidated whole profile that will describe a whole use case and take care that they are actually compatible between different vendors. And then once all of these technical requirements have been fulfilled, there's still the question of whether we can actually compare similar lab values that come from different providers to find out whether they are actually the same or whether they're just similar. If they've used different methods, different normal ranges, it's quite important to also have detailed descriptions of the methods to make them transparent, and also to use other quality increasing and standardization measures like ring trials in order to improve the comparability of these results. Okay, and then finally, challenge once all of these previous things have been established and met, of course, is the presentation and visualization of these data elements that have been put together, because it's just such a broad range of data elements from various points in time with different temporal spacing, etc., that it can be quite a challenge to actually bring that to the users. And for the doctors, the initial problem will be to have an intuitive way to actually select the relevant data elements from these large databases for their individual patient or for larger cohorts of patients. And one way to address that is a semantic navigation, to use the actual structure of meaning in the database, to use the structures of the different terminologies, the hierarchy levels, in order to make these databases available for users. And also, we have the problem of having these disparate sources of information, diagnoses, lab values, medications, collected at different points in time. And so we need to find ways, novel ways to visualize these pieces of information so doctors can actually make use of them, like for instance timelines or stream graphs that show different elements of data over time, or also to combine different kinds of visualizations in order to give an integrated view of these different data elements. And then, as I mentioned in the slide before, lab values may be similar but may not be identical, for instance, due to different normal ranges, different value measures, and it may become necessary, for instance, to carry out scale transformations if that is possible, for instance, using a Z-log methodology in order to transform these values to a common scale for display in a shared visualization. And then regarding the patient, the question again is how can we provide a comprehensible visualization to the patient of all of these broadness of data? And certainly this is going to need a mobile touch-based apps which allow the patient to intuitively navigate between the different pieces of his or her health record, but maybe also reduction to relevant features to really find out what kind of information a patient would actually need in a specific situation. However, we need to take care to see that the needs and capabilities of patients could vary quite widely, because if you have a chronic disease and you are involved in your disease, then certainly you may need a visualization just as complex as the one that the doctor is using. And tomorrow morning, I think the first talk is going to be about just this kind of aspect of presenting data to patients in a comprehensive way. And now I'd like to switch over to the initiatives which are currently going on in order to address these challenges and achieve these potentials. And the first one I'd like to show is the German Medical Informatics Initiative, or MII. It's a rather large funding initiative by the German Federal Ministry of Research, which provides about 150 million euros over the next 4 years, funding 4 consortia, which are spread pretty much throughout the whole country of Germany. And this northern part, which has been left out, is currently being filled by the universities there joining the other 4 consortia. And the goals of this funding initiative is to establish local data integration centers at pretty much all of the German university hospitals, which allow to pool the data in local data warehouses in an architecture pretty much like the one described by Professor Roker in his presentation. and which will allow them to locally evaluate and analyze and utilize their data and also monetize their data. But the next goal is, of course, to achieve an interoperability across the sites within each consortium, but also across the different consortia and also on an international level. And one technique that is being used in order to achieve this interoperability, among many others, is the discussion and harmonization of a shared MII core dataset, which also contains a laboratory module, which of course is based on LOINC. And this is going to be an important aspect of the project to really establish LOINC in Germany through this project. But the project and the funding initiative is not just about implementing technical infrastructures, it is also about showing the actual success and the functionality of these infrastructures based on actual clinical use cases, which are also implemented in these 4 years of the project. And finally, another goal of the project is to strengthen medical informatics by providing additional teaching units, increasing the number of medical informatics professors at German universities in order to ease the lack of personnel that we have, because medical informatics was not very much supported in the past 10 years in Germany. And there are actually lots of similar initiatives like the one we heard from Professor Roca in Catalonia, but there's also European initiatives like the Swiss Personalized Health Network, SPHN, or EDEN, which is a project which is just about now starting, which is the European Health Data Network, which is going to include lots of hospitals throughout Europe in a similar structure, just like the German Medical Informatics Initiative, also using similar technologies. And I'd like to go into a little bit more detail with one of the consortia, because I'm also active in this consortium. It's called MIRACUM, Medical Informatics in Research and Care and University Medicine, which is currently the largest German MIR consortium with 10 university hospitals and another one in talks to join, which currently has access to more than 12 million patient records, mostly inpatient records, of course. And it has clinical use cases which have some similarities to what we heard in the first talk in this session. First of it is a recruitment support for clinical trials, just as I described before, as a potential to use the totality of the clinical record of the patient in order to provide them as candidates for clinical studies if they match the inclusion and exclusion criteria, which is more like a medical informatics methodology use case. But the first clinical use case is actually the creation of a prediction model for COPD, asthma, and neuro-oncology, with a focus on implementing federated methods of machine learning, with keeping the data inside of the hospitals, also like you described. Because of data protection reasons, we cannot pool the data. They have to stay inside of the hospitals. So the analysis programs, they travel around and go to the individual sites and carry out partial analysis there. And we're going to use cryptographic methods in order to pool these analyzed and aggregated data in the end and achieve machine learning models for these diseases, which will then be used for decision support for endotyping, finding subgroups of these patients. And the final use case is precision medicine for molecular tumor boards. And there are two focuses here, with the first of one, which is to establish standardized bioinformatics pipelines between all of the participating sites, and also the visualization of findings, which can be quite complex regarding molecular tumor boards. Okay, and then finally one international initiative which just shows the size that can be reached if you set up the right infrastructure. It's the Odyssey collaboration, which stands for Observational Health Data Sciences and Informatics. It's an international collaboration for the secondary use of routine clinical data. And its highlight feature is that they've provided a very detailed common data model containing structures but also terminologies which are standardized throughout the whole collaboration, which makes it easy to have comparative data sets in various collaborating countries. And of course, regarding lab data, they also include LOINC-coded tests and data structures. And besides these common data models, they also provide a set of integrated tools for cohort discovery, statistical analysis, but also for federation and automatically carrying out these analyses across the the whole collaboration. And using these approaches, they have now gathered data of more than 500 million patients across a large set of countries spanning the whole globe. All of that data is not pooled in one place, but it's rather stored in their own local locations. And some of the national databases, like the one we heard of the UK right now, as far as I know, have also joined this collaboration, or also the Dutch data set or Korean data set. And some published analyses from these large-scale collaborations is, for instance, here this diabetes visualization, which shows the different pathways of patients throughout different kinds of medications. For instance, in this inner circle, you see that most patients start with metformin, and many patients stay there. They just receive this one medication, but other patients need to change over to a different medication. And some patients will then need some additional medications like 3 or 4 times. And this was carried out on a cohort of about 200 million patients. And what we can see on the right-hand side is current ongoing studies, like for instance, analyzing the outcomes of different pharmaceuticals for psychological disorders on a large scale using statistics to derive, for instance, unwanted outcomes or outcomes for these medications across these large sets of patients. Okay, and then finally, regarding personal access to health data and patient empowerment, it's a lot more disparate. I think some of these activities are government-driven, like for instance the Blue Button initiative in the United States, which allows you to download a personal copy of your data out of an EHR system in a fairly standardized format, the HL7 continuity of care document, which can then be used for referrals to other physicians, or also as a data donation, where you take your Blue Button download and donate it to science. Other academic initiatives are, for instance, the PEPA, the Personal Electronic Patient Record here in the Heidelberg region, which is being coordinated by the Heidelberg University Hospital. And it provides interfaces between the different providers for inpatient and also outpatient care, which is uncommon in Germany because these systems are usually quite separate, which is a very positive feature of this platform, and also it is controlled by the patients. They decide which kind of data gets transferred to their providers and which has to stay inside of the individual participants. And then there are also insurance-driven initiatives like TK Safe or Vivi in Germany, which are provided as part of the insurance coverage. So theoretically, there's a very large part of the population that could make use of that, millions of people actually, but the actual uptake is still quite low as far as I know. And then maybe more in the press and in the media is the vendor-driven approach, like for instance Apple Health, which recently upgraded their healthcare app on the iPhone to also integrate hospital information data, which is accessed through HL7 FHIR interfaces. So again, this very important ongoing standard is being used there, and it's integrated with the data which is collected on the device, like all of the pulse tracking or motion tracking which is in there, and it can be reused for research purposes and also care purposes if the patient agrees. So again, the patient is fully in control of what happens to his or her data. So to conclude my talk, I think that digital networks do not mean the end of laboratory medicine as we know it, but rather it provides new opportunities to integrate with other fields and provide an important piece of information for the holistic view of the patient record. So it's really an opportunity for integrating fragmented data silos and to implement novel ways of visualizing data, analyzing data, and providing decision support. Of course, multiple challenges need to be addressed to achieve these goals, but fortunately several initiatives are already tackling them. Most of them are large-scale initiatives on the academic field, like the Medical Informatics Initiative and similar projects in other countries, whereas the integration in the care process still appears to be quite daunting because of these strong barriers between, for instance, the inpatient and outpatient field that we have in Germany and the different kinds of information systems that we find in these areas. So thank you very much for your attention.